All right, welcome everybody to our podcast. Still not sure what that means. Okay, but here we are, and we're looking at this famous podcast with Big J
and Little J,
and we're from the OT Helpdesk. And today we're going to talk about answering test questions. That's right. It seems to be a hot topic out there. I guess because there's 170 multiple choice questions on the big NBCOT board examination, and at the end of the day, students, they're concerned about getting them right. Is that safe to assume?
Sounds about right.
All right, Smarty. So when we step back for a second, because we've been doing this forever, okay, what do we know? Okay, like, what do students fear the most about this big bad examination?
I would say they fear taking the test, getting to a question and being able to narrow the answer choices down to 2, but then not being able to narrow it down further from there. So basically getting to 50-50 and not knowing the answer from that.
Well, I absolutely unequivocally hate that statement, okay? Because I think it's a bunch of crap, okay? But that's just me, okay? Because I wasn't brought up in that one, okay? Hey, did you ever go into your doctor's office and the doctor say, "Hey, little J, I've been watching you on OT Helpdesk, but here, I got news for you. I've been working on your diagnosis and I got it narrowed down to 2. Yeah. And I heard that if I get rid of 2 answers, that are similar, that I can find the answer somehow a little bit easier that way." Do you really believe that?
I mean, that sounds like a pretty typical doctor's office visit for me. Is that not the way it's supposed to go?
Yeah, well, that kind of explains, some of the things that you've been taking, medications and things, because I know you got like a cabinet full of them, and every 2 seconds, you're not sure what your diagnosis is. I'm sorry, I can't do it. I want to, I really do, okay? But at the end of the day, here's my thought. At the end of the day, okay, there's a reason, okay, why you're not able to answer a question. All right. And I'm going to be the bearer of bad news. Okay. Because there's a few reasons that I can think of right off the top of my head. And we're going to do some, questions. But here's my thought. You don't know something in the question. Because when a question gets harder and harder, the truth is, okay, you're dealing with more factors in a question. And when there's more factors, it's requiring you to spend a little bit more time, okay, with critical thinking and reasoning. Yeah, okay. I'd love to say clinical, okay, reasoning, but it's, if you step back and you don't know something, then you don't know something. So the key, and we'll talk about that in a little bit, about some things that we need to know. Okay, the key would be is that you really have to begin, okay, when you're studying, with looking at a way, okay, to understand information, not just memorize it. I know people heard that over and over again, but I don't believe, okay, that memorization really cuts it unless you do something with it afterwards. I'm okay with memorizing the Ranchos Los Amigos. I don't have a problem with that. But if you don't use it and you don't apply it to something, I don't see how it's not going to fall off the back of your head and not be there when you need it. Okay. And I think a lot of people experience this. So let's think about a little bit more of an approach, okay, that you might want to consider. And let's think about a CVA. All right. So whether it's a CVA that's acute, or whether it's a CVA in rehab. Joseph, start me down the process when you hear in a question that the individual has a CVA. What's the first thing that an OT should be thinking about when it comes to like a CVA?
So I'm always thinking about their mental functions. So memory, attention, and concentration, their higher level cognitive stats, like their executive function and
That's
problem.
great. That's great. That's going to work. Okay. All right. It might have helped you when you were on field work. Okay. Yeah, it might have helped you. Okay. But what's the first thing, okay, that we do when we're with a client? What do we establish first?
So we're going to ask them if we're going to figure out if they're alert and oriented person.
There
place,
you go. If the pace are they alert, oriented, person, place, and time and situation? That's a pretty basic concept, don't you think? Yeah, it is. Okay. Well, but see, again, here's the problem. We're coming back to this, right? And what's going to happen is you're thinking like you were in field work. Okay. I'm not. I'm taking the boards. So on the boards, okay, there's going to be this heavy process around this thing called the OTPF. Yeah, do you know what that means, Joseph? The OTPF. Can you say that?
OTPF, Occupational Therapy Practice Framework.
All right, there you go. All right, now you ready? I'm going to give you a question. Everybody listen. No, I'm not going to let you see it. I want you to listen. I'm going to read it twice. You ready?
Let's do it.
Okay, a client who has experienced a CVA is being seen in an inpatient rehabilitation facility. During the evaluation process, the OT is assessing specific mental functions, period. Which of the following represents an example of one of these functions? A, orientation. B, visual acuity. C, visual perceptual ability. And D, energy and drive. I'm going to read it again. A client who's experienced the CVA is being seen in an inpatient rehabilitation facility. During the evaluation process, the OT is assessing specific mental functions. Which of the following represents an example of one of these functions? A, orientation. B, visual acuity. C, visual perceptual ability. And D, energy and drive.
You changed it up on me there, John. This is not the question that we practiced when we were kind of going over this earlier. I don't have it in front of me.
Well, you should be able to get it, Joseph.
I think I can.
This is a clinical reasoning question. You're supposed to reason.
I can still get it. I've got it. All right, let's start with the first one, which I believe you said was orientation, right?
First one's orientation.
So we already kind of reviewed that one is a global mental function rather than
9 out of 10 people answer this orientation.
But I'd get rid of that one because I'm looking for more of a specific mental function versus more of a global one. So I need to get rid of A. All right, the next one. Tell me what B was again.
Visual acuity.
I know it's definitely not visual acuity because when I'm thinking of that, that is more of a sensory function because visual acuity is just the clarity of vision. So it's not requiring me to actually process anything that I've seen or perceive anything that I've seen. It's just how clear my vision is going to be. So it's more of a sensory function versus a mental function. So I'd get rid of that one.
C, visual perceptual ability.
Yeah, that one sounds to me more like a mental function because I have to take what I've seen and I have to process that, and my brain has to make sense of what I'm seeing. So
yeah, I like what you said. You said more of a mental function. Is it a global mental function or a specific mental function?
Specific. It's a specific.
That's right. Say it. I know you always have problems with that and say Pacific.
Specific.
Yes. All right. So and then the last one is energy and drive, and you're not picking that one. What is that, Smarty?
No, energy and drive is more of a global mental function too.
Hey, you know what we could do here? We could say, let's see, A and D are similar, so we'll get rid of them.
No way.
Oh, okay. Yeah, they're global mental functions, right? Plain and simple. See, if you knew they were a global mental function, then you knew A wasn't right and you knew D wasn't right. You know what I like about this question? It's a lower level question. It's a concept question. You either know the answer or you don't. Don't play the game with me that you got it down to 2, because if you got it down to 2, you don't know your OTPF. That's the reason why you get this question wrong, right? I mean, that's the key. And that's what I want to make sure that people hear me say, because lower level questions in some of the tests that you take, they're not preparing you for a high level question, are they? What if you didn't know what that was? Might not be a bad thing, right?
Right.
Because then you could go back and you can say, okay, now I get it. I really got to practice knowing the difference between global mental functions and specific mental functions. I like that. Never turn down a question, right? I love questions. I don't care if they're easy. Hey, a win's a win, right? But when you get to the boards, it don't work like that. They're not giving you a softball. That's a softball. And if you're having trouble with that one, okay, you don't know your OTPF. And that's one of the things that I just want to make sure that we think about. Okay. So that's when you study, that would be one of those things to really kind of have questions that you could go down through and you can see again, because when you were in school, you kind of forget about the OTPF, don't you? When you go to field work. And then all of a sudden you're back here and somebody's handing you this huge book that says you got to know everything in it. That scares the bejeebies out of me. Okay. And a lot of students. Okay. But, so we really need to think about it. All right. So let's talk about, and I'll mention this. What do we use in the OT help desk to help students with this? Because there has to be some type of a model that you use, okay, when you're studying. Because if you don't have a model, okay, which I find that most students don't, okay, then what are you using? What's your thought on that, Joseph?
So here at the OT Help Desk, we just used our best educated guess. Just kidding there. We use the Wingman. And if you've ever watched any of our YouTube videos before, or even listened to some of our podcasts that we've had, or of course, if you're a member of the OT Help Desk, then you know all about the Wingman, right, John?
That's right. When we first created the Wingman, which goes back years and years and years and years, okay, the idea behind it was that you needed a process, and everybody goes, the Wingman. Well, the Wingman is a glorified OTPF. That's all it is, okay? Only it isn't a model anymore, or excuse me, it's not a OTPF, it's a model, okay, that uses a process for thinking. The OTPF does not do that. The OTPF has the OT process, which makes sense to me. This is what we should do. And it has all of the elements, okay, of what we should know as OTs. So you got to remember, it's not a theory, it's not a model, okay? It is just a taxonomy of language that we all agree on in the profession. So when you write the boards, I would assume, okay, based on what I know, is that they're going to use the OTPF. All right. Seems logical to me. How about you?
Seems pretty logical.
All right. Yeah, you're like a parrot. Thanks for saying that. I appreciate that. All right.
I appreciate that.
I want you to mean it. Yeah, I want you to mean it. All right. So, I mean, the idea behind it is this, is we want to be thinking the same way with every question. So let me give you a little tidbit of information, little J. Okay. Sit down and write out exactly how you answer a question. Because it's real important for you to self-assess yourself. Write it down. Okay. Because how you answer a question should be the same way every time. Will it change? Yeah, it changes. Okay. Because the information changes. Okay. Imagine this, right? Diagnosis, a patient is a CVA. Okay, got it. Okay, who is currently being seen in an acute care hospital. Got it. CVA, acute care. Okay, the patient is being seen by the OT for at bedside. Okay, got it. For an initial evaluation. I got a CVA, we're in acute care, and we're seeing them at bedside for an initial evaluation. Now what? Well, yeah, actually, that's just the lead-up information, isn't it? Okay, that's only going to help us with what's the diagnosis, what's the setting. Diagnosis, etiology, and prognosis is what my brain thinks about. Okay, CVA, I immediately think about it's a CVA. They're currently in an acute care hospital. Okay, what's that mean to me? I'll tell you what it means to me. It means at right out of the gate, safety, awareness, ADLs, and sometimes positioning. That's what it means to me.
Right.
Now you tell me it's rehab. What do you think of, Joseph? If I don't say acute care and I say rehab, what do you think?
When I think of rehab, I still think of ADLs, but then we might also be focusing more towards some IADLs. And then of course, safety awareness is going to be, that's going to be a big focus, just like it would be in acute too.
How many hours do you get to work with somebody in acute versus rehab, Joseph?
Acute is going to be typically pretty brief. Rehab, of course, is going to be much more intense. So it's going to be, you're going to have to see them for 3 hours a day, 5 to 7 days a week. So it is, definitely between all the disciplines, of course, not just from OT, but definitely you're going to be more intense there. But I think another thing to, that you mentioned there, John, just to kind of piggyback off that, is think about what he said there. We're in the acute care setting and it's an acute CVA. So anytime we have an acute CVA, that also tells us something about our diagnosis and prognosis is important there. So like if I was looking at my answer choices, for example, if I have an acute CVA, I'm probably not looking for something that involves adaptation because we're still in the phase of the CVA where remediation could potentially be feasible. And so that tells me a lot, even just thinking about the stage of the injury or the illness or the diagnosis that they're at, because that's going to lead us to whether we're going to be remediating or adapting, compensating, and thinking about their potential prognosis as well. So that's another component of the wingman we have to consider with the diagnosis is where they're at in terms of the level of their injury, how far out they are from the diagnosis, the acuity of it, those types of things.
You're like this little encyclopedia. Okay. Now, what every student just did listening to you has said, oh my gosh, I need to know the difference between remediation, compensation, and adaptation. You freaked everybody out, Joseph. That's what you do. Okay. Now, listen, let's think about remediation, compensation, and adaptation. Isn't it like a big question? Everybody asks that, don't they? They all get caught up on that, don't they? All right. So when it comes to a question, just what you had just said, I like that. But give me something to sink my teeth into. So if I'm going to think about the difference between remediation, compensation, and adaptation, what might I ask myself?
So remediation basically would be, am I going to want to get this person back to join their occupations in a similar manner as the way they did them before? So like, let's say you have a stroke and you're working on upper body dressing. The principal remediation would say, I want them to incorporate their involved upper extremity into the task as much as they can so that they can get back to doing it with the same task demands that they did before. Because obviously most of us don't do a hemi dressing strategy. Most of us use both our upper extremities to put on a shirt.
Well, you know what? I've seen patients walk in acute care, not walk in, be brought in by an ambulance, okay, and they have a total, hemiplegia. They're flaccid on their right and upper extremity and lower extremity, and then 3 days later walk out.
Right.
So that's why I always say you wouldn't want to start with compensatory and adaptation with somebody in acute care, right?
Exactly, because there's still that chance for recovery. So you want to make sure that you're giving them that opportunity and trying to remediate, as you're able to, as your initial focus of the goal.
All right, Smarty. So what if I have an individual, okay, who has a spinal cord injury, a C6 Asia A? What am I doing? Am I doing remediation, compensation, or adaptation? A C6 Asia A.
You're going to be working on compensation and adaptation with this person because it's different. Again, we have to think about our prognosis of this. The prognosis of the acute CVA, there's some potential there for remediation, but we know that with an Asia A spinal cord injury, that's a complete injury, and we know they're not going to get any return back. And so we have to start thinking about ways to compensate and adapt because we can really pinpoint, what their prognosis is going to be and look at it from that perspective.
So now let's do a C6 Asia C. Now what do you got?
That's an incomplete injury.
And then, so what are you doing? So remediating, compensation, or compensating or adaptating?
So adaptating.
I like that.
So you could be doing a combination of all three. Your initial goal might be to try to remediate, but while you're in the process of that, let's say that you're, a couple of weeks into the process with them and maybe they're not demonstrating return at this point. Let's just say you're in an inpatient rehab setting. Maybe you focus on, compensation and adaptation so that they can be safe and do these activities as independently and these occupations as independently as possible once they discharge home. But then, of course, if they do start to get more return, then maybe they continue with their therapy in a different setting, maybe a home health setting or maybe an outpatient setting where the focus could be on remediation again. And that kind of applies to a number of diagnoses. Again, if we're not thinking of something like a complete spinal cord injury or a neurodegenerative diagnosis where we know they're just going to continue to progressively decline, usually your goal is going to be on remediation. That will change maybe a little bit for some orthopedic injuries where they might have a non-weight bearing status, and we have to think about that initially. But again, that's why it's really important to think about these diagnoses individually and think about their prognosis.
All right, okay. Man, go on and on and on. You're like a dictionary. Okay.
Well, I could. I just because I think people
you're reading off of something, aren't you?
I'm actually not. But I think people kind of fall in the trap of wanting a black and white answer for every diagnosis across the board. And we just can't think of it that way. That's why we have the wingman, because we have to think about each diagnosis on an individual basis in relation to its prognosis and what we're going to.
All right, okay. Then here's what we're going to do. I'm going to give you something, okay, and you're going to tell me whether it's remediation, compensation, or adaptation. You ready?
Let's do it.
All right. An individual, okay, has a total hip, all right? And the individual has been provided a sock donor. What is it?
Sock donor. I am gonna say that's compensation initially, because you're not gonna need it permanently. You're just gonna be using it initially until you don't have to follow those hip precautions anymore.
All right. Okay. All right. So an individual has a CVA and the OT is working with the individual and they're doing a paper. They're sitting down and they're looking at letters, okay, and canceling out letters. What is it? Remediation, compensation, or adaptation? And explain to me why.
It sounds like a remediation task for neglect or hemming attention, because you're trying to remediate that skill by doing the pen and paper type task there.
All right, you ready?
Ready.
An individual has a CVA and they're approximately 1.5 years post CVA. Okay, and the OT is making a splint for a anti-deformity. Okay, what is it? Is it remediation, compensation, or adaptation?
So when you said 1.5 years post CVA, that automatically was a flag to me that this is going to be adaptation, because, again, with this diagnosis, once we're out of that initial 3 to 4 months there's not really as much of a chance for improvement in terms of their, in terms of motor return or anything like that. So then you are going to be geared more towards adaptation.
You're tough. All right, I'm going harder. You ready? An individual is status post 9 months with a CVA, and they show up at an outpatient center, okay, and the caregiver, we'll call it a wife, of the individual, male individual, and they are in the clinic, and the wife says to the client, you're supposed to look to your other side, and she's getting really frustrated and upset about, finding something that's on the other side, and the person, the patient just can't do it. Okay. So, and that's like an anchoring technique, right? That she's trying to use. Now, what does the OT do at this point?
So 9 months, again, that's too far out of the initial stage. So I would probably talk to the wife about adapting, making sure that she's standing to their side that they're attending to, making sure that all of the items that are relevant to the patient in any given room at home are going to be, able to be accessed on the side that he's attending to, because it's just not, unfortunately, it's not something that's going to be feasible anymore to expect them to gain an awareness of that at 9 months, after the stroke.
All right, I'm done. That was pretty good. So remediation, compensation, and adaptation. Let me just give you another little tidbit to think about. When you look at the three of these and you're dealing with something, just ask yourself if the person is going to have to use whatever it is for the rest of their life. Okay, that's a real good way to help you initially through the process. All right. All right, we got to do one more thing here. And then, because I know we're doing this in series, so let's do another lead up. Okay, but this time we're going to use our favorite. We're going to use splinting. Everybody talks about splinting. Let's talk about it. All right, Joseph, I'm going to ask you a question, low level question. Okay,
Right.
An individual has Decoding veins. Okay, no, it's not a tequila, Joseph. Decoding veins. All right. And the doctor would like you to fabricate a splint. Which splint are you going to fabricate? You ready? A resting hand splint, a thumb spica, a figure 8 splint, or an ulnar gutter splint. Which one are you going to do?
All right, so I'm not doing the resting hand splint because that would immobilize the whole hand and wrist, and I don't need that. I just need the radial side mobilized. The thumb spica splint makes sense because I know Decoding veins. I know my etiology of that is going to be the overuse of the muscles in the first dorsal compartment there, the extensor pollicis brevis, abductor pollicis longus. The thumb. What's that?
Keep going.
Sorry. So I know that that's going to be the one that would make sense for that. We have C. What was C again?
We had the figure 8.
No, that one's going to be used more for like if I have median and ulnar nerve damage to bring the MCPs into flexion. And what was D one more time?
And where would that damage be to the median and ulnar nerve?
It would damage the lumbricals. That would be denervated.
Okay. And then finally, the last one was the ulnar gutter.
No, that would be more for like a boxer's fracture, like when you have damage to the metacarpal.
All right. Okay. So let's go to the next level. An individual has stenosing tenosynovitis of the first dorsal compartment with inflammation to the extensor pollicis brevis and the abductor pollicis longus, and the individual tests positive for a Finkelstein. That's right. What is it? The diagnosis so far. What are you thinking?
Decoding veins.
Too easy. That's a higher factor question, and I could put in there possibly a comorbidity or something like that, right? Okay. But now the doctor wants you to make a splint. You ready?
Ready.
All right. A hand-based thumb spica with the thumb positioned in radial abduction. B, a hand-based orthosis with the thumb orthosis with the thumb position in palmar abduction. C, a forearm-based thumb spica with the thumb positioned in radial abduction. And D, a long opponent splint with the thumb position partway between radial and palmar abduction. I want you to stop right there. What I want to remind students of is this is a higher level question. Okay? So what I'm going to do is I'm going to step back for a second, and I'm going to do something that we do in the OT help desk. Because if you're going to sit there and try and guess at this question, and right now we already set you up because we already did the first level, and you already talked about dorsal compartment, yada, yada, yada. Okay, so now there's some things that you need to know, and this is the point of what I want to bring across to today. Okay, that sounded a little bit stutterish, didn't it? To today. All right, but what I want to make sure that I do is this. Okay, I want you to remember that to answer this question, you should be able to clinically reason. So let's back up. What are the things that I need to know? Clearly, I need to know what a stenosing tenosynovitis is.
Mm-hmm.
That's an inflammation, okay, period. Now, it's real interesting because this one was in the first dorsal compartment. Okay, So you probably should know what's in the first dorsal compartment, right?
Right.
Right. Then it went to the idea that we have an inflammatory response to two tendons. And then it went to an assessment, which is the Finkelstein. Too easy, right? Because most people who know that are immediately going to see it. But see, we're not giving you the first question. That's right. We're not asking you about a thumb spica and dequerbanes. And when it shows up, sometimes it's not always going to come out of the clear blue for you. Now, here's what I want to do in this question. I want to ground you immediately. And I want you to think about a very basic anatomy, okay? We got right here, we got the flexors of the forearm, right? Flexors, okay? Yeah, you want me to go over them, Joseph? Yeah, I can do the same thing. Palmaris longus, superficialis profundus. Trust me, I can nail them, and I'm not looking at it, all right? So, there you go, Rain Man. All right, so here we go. Now, the next thing that we know over here is these are the extensors. What are the three, Joseph? At the lateral epicondyle, what are they? All three of them. Extensor carpi radialis longus, brevis, and digitorum. There, Okay, they come out of here, right? Their muscle belly, they come down here. The tendons cross the wrist, and they help us do what motion, Joseph?
The carpi extend the wrist, and then the digitorum extends at the MCPs.
Perfect. All right, so we have, why couldn't you just say wrist extension, Joseph? Really? Okay. All right, so we got wrist extension and we got wrist flexion, right? Well, we got the same thing in the thumb. You know, we've got extensors that allow us to do this, and we've got flexors that come down here and allow us to flex, right? Now, here's the thing. It's interesting. All of these muscles, all of them, every one of them that are back here whose tendon crosses the wrist, they all share one name. What is it?
They're extrinsic.
They're extrinsic muscles. And if you can't answer that immediately, because a lot of people can't, then you're not thinking clinical reasoning. Because immediately we know that these are extrinsic muscles. The two that are involved, extensor pollicis brevis and the abductor pollicis longus, they're extrinsics. Okay, now, if these guys are all extrinsics, what are these guys? Anything from the wrist down.
Intrinsic, anything that originates.
You got it. And those guys, real easy. Lumbricals, interossi. What are these?
The thenar muscles.
Thenar muscles, and what are these?
Hypothenars.
Great. There's only 4 groups. So let's not get in a panic about it. And they're intrinsics. Now, here comes the reasoning process that we need to think about. Usually, anytime you have an extrinsic muscle that's involved, meaning the tendons cross the wrist, we should be making what type of splint, Joseph?
A forearm-based splint.
Forearm-based splint. Easy to know, right? And that's reasoning. And anytime we're in the hand with an intrinsic muscle, what's logical there?
A hand-based splint.
So we've got forearm-based and hand-based. Now let's go back to our question, okay? Because we're making a splint, okay? And the doctor wants to know, A, if you're going to make a hand-based thumb spica with the thumb position in radial abduction. What's your thought?
I don't need a hand base for dequerbanes because I'm looking at extrinsic muscles. And then also
got it. So A is not an answer, right? So,
right.
And B is a hand-based, okay, thumb orthosis with the thumb position in palmar abduction.
I like the palmar abduction better, but again, I don't need a hand-based one.
Got it. So no, people, we're not getting rid of A and B because they're similar. Sorry. We're getting rid of them because, okay, they're intrinsic based and we don't need to know it. So I'm not playing the game because I'll tell you what, people have gotten rid of, okay, the wrong answers in a case like that and picked A, which is the thumb spica. So be careful. All right, now we're down to 2, right? Logically, okay, we have a forearm-based thumb spica, and we've got a long opponent splint, okay, in that. Now, one is a forearm-based thumb spica with the thumb in radial deviation or radial abduction. And then the next one is a long opponent splint with the thumb partway between palmar and radial abduction. So I want to illustrate something. So here's how it works. Okay. An individual, when they have, at this point, when you're down to 2 answers, because this is what everybody wants to know, right? So let's just talk about this today, and we'll pick it up next time in. But in this particular case, when we're down to 2 answers like this, stop a second, and I want you to remember something. When you get to higher level questions, logically, higher level questions are going to occur on the boards, When you're looking at a higher level question, the smartest thing to do, is to understand that when you get it down to 2 answers in this particular case, what you want to do is you want to step back and you want to think about, how they're similar, and then think about how they're different. In the rule of standardization, we look for the idea, that, when we get it down here, we know 2 things about this question, When I stop and think about a forearm-based thumb spica, and then I think about a long opponent splint, they're the same exact splint. So dangerous, right? Because if you're playing with that concept, and this is what I've seen students do, I've seen them get rid of C and D because they're similar, and then they pick A. Well, that's a winner, or they pick B. I've seen them do that because of what you said, palmar abduction, But the thing is they are similar. But what you have to do now is you have to contrast them. And the contrast is where it makes a difference. Because in this case, one is a radial abduction, which is C, and you would never position the thumb in radial abduction for a de Quervain's. You may position it there for a third dorsal compartment with the extensor pollicis longus, and possibly a severed tendon or something, lacerated, but you're really going to think about this, not full palmar and not radial. You're going to go part way in between. And that's the answer, which is D. So, all right. So we've kind of talked about some things. So again, how do I study for this question? Well, what we do at OT Helpdesk is in every lesson that we do, because we do lessons as well as lots and lots of test questions. But in every lesson that we do, we talk about as an example, what we talked about in the OTPF. When we do hands and splinting, we talk about this scenario, because these are ways to clinically reason. See, I'm about clinical reasoning. And the way I just explained it is really honestly how you should be looking at, forearm-based versus hand-based, and, it's more of an evidence-based process. That process comes, from the Hand and Upper Extremity book by Osteophytis and Saunders. Things like that are going to make a difference. All right. So, so step back for a little bit. Come to the second and third presentation here. Get a little bit of feel for what we're doing, or better yet, come join us at OT Helpdesk because we do this every day. Monday through Friday. We have open sessions and we have topic sessions. On Monday, Wednesdays, and Fridays right now, for example, they're live. On two other days, they're recorded. And we record the live session and put it up there. That's one example of what we do in the product, but that prepares students, to take test questions. And we do a lot of what we did here today, but we do it every day. And when you practice this process, Joseph, I'll ask you, because I know at one point in time, years ago, you did this process. What was your thought about how did it work for you when it came to the boards?
Yeah, I mean, the Wingman is great. I'd say that's the biggest thing that we hear is that a lot of students just say they didn't have a process before they came to the OT Helpdesk. And once you really practice using that, and like John kind of mentioned there, in the open sessions is really where you can practice using that. When you join us at the OT Helpdesk, that makes all the difference when you have that process to help you approach a question.
All right. Okay, well, thanks for joining us today for this wonderful podcast. And we'll be picking up on the next podcast. And what we're going to do is we're going to kind of extend that. Okay. And we're going to take the concept of what we were doing here today and we're going to build on it. So if you're following it, not a bad way to kind of build your expertise in how you're answering questions. Go try a few of these. Okay. Better yet, come join us at OT Helpdesk. Also look for the coupon that we have, for OT Helpdesk, and, we can get you in a little bit cheaper. So anything else, Joseph?
That pretty much covers it.
All right. Well, then we'll see you in the next podcast.